Well, good afternoon, everyone, and welcome. I know people are still dialing in, but we wanted to go ahead and get started. A couple of super quick housekeeping things. As always, the slides and the recording will be available on the We Honor Veterans website resource page. It'll be up in the next couple of days, so stay tuned, and then we'll be sending out an announcement as well. We're encouraging you continue using the chat function. If you have any questions, feel free to post them there. It's just easier so everyone else can see, and it's likely that if you have a question, someone else is thinking the same thing. But if you're more comfortable using the Q&A, do whatever feels right. Another super quick announcement, just wanted to let everyone know that our trauma-informed care initiative is officially continuing on. More information will be coming, so please stay tuned. And if you haven't registered yet for next week's forum for We Honor Veterans Partners, please feel free to do so. That's on the 16th. It's up on the events calendar. So without further ado, I want to hand it over to our panelists now.
Thank you, Catherine. My name is Jenny Moy. I'm a psychologist at the VA in Boston, and I'm here today with a bunch of our team members who I'll introduce to you in a moment. We have a pretty simple and I hope enjoyable webinar planned today where we are going to be sharing with you 3 videos. Each video is about 10 minutes, and we'll be wanting to discuss and get your feedback on those videos. I want to begin with a few words of thank you. We want to thank Dr. Scott Shreve from the VA Office of Hospice and Palliative Care, and of course, We Honor Veterans and NHPCO. We also want to acknowledge Tipping Point Solutions, who was the contractor who worked on these videos. If you think, wow, those are terrific, well, we can't take too much credit. We certainly contributed, but they and the amazing actors they hired really did a very professional job. So thank you to Tipping Point. And especially we want to thank the VA Office of Rural Health, who provided the funding to develop these videos. We developed these videos based on surveys and interviews with hospice and palliative care providers who serve rural veterans. We think what you will be seeing will be relevant to wherever you serve, but we want to particularly thank the Office of Rural Health for their support. But most importantly, the first line of this slide is we did do, as I mentioned, surveys and focus groups with about 250 people, and I'm hoping some of you might be on the call today. So we wanted to thank you for sharing your thoughts about how do you see PTSD present in veterans at the end of life, and also sharing some of the wonderful, skilled and compassionate responses that you have developed. And we hope you'll feel that that is reflected in the video content that we're going to be sharing. On this slide is the members of the team here in Boston who worked on these videos. And we've asked anyone who's on the team to change their username so that you can see who they are, to identify their discipline, and just put video team. And because we don't expect you to quickly memorize 8 names. You'll also see these names popping up today in the chat because we have questions for you and we want to respond to questions you have. And so you'll see these individuals responding. And in particular, at certain points, you'll hear from Dr. Zach Sager, who's a palliative care physician and psychiatrist, who is sort of co-emceeing with me today. So I want to share a few tech tips before we move on. We'll be sharing the videos through Zoom, and that should work for most people. If you're having problems, or if you anticipate, we've all become kind of very tech savvy this year, haven't we? And if you know you have 3 kids at home on your bandwidth, you can quickly scan this QR code on your phone and watch the videos on the phone. We'll also be entering the links. These are on YouTube, so we'll be entering the links for those in the chat. You shouldn't have to use that, but if you're having problems, that would be an alternative way for you to access the videos. We also want to just share a personal tip. So these videos deal with trauma and PTSD. None of the content is graphic in nature, but we think they're sort of emotionally evocative. And so we want to just prepare you for that. And again, I think it's very touching to see the job that the actors did in portraying both veterans and the compassionate responses of hospice and palliative care clinicians. So before I move to the next slide, did I miss anything? Anyone from our team have any points? Okay, we're rushing a little bit because 3 videos of 10 minutes each. We really need to leave some time to view those. So the first video is presenting an early visit. It's actually 2 different veterans, 2 different clinicians. So it's early visits with these veterans, and where the clinicians are just starting to see signs and symptoms of PTSD. So we thought that as you're watching this video, you might want to do that same thing, sort of look and see, what are you seeing that makes you think this looks like PTSD? The sound will come on in a minute.
Hi, how are you?
I'm doing really well.
Good
How are
morning.
you?
Come on in.
Thank you so much.
Yeah, so good to see you, Chad.
Can I close this?
Yes, please, thank you.
Hi, I'm Tiffany Webb.
Can you not read?
Mrs. Heltzel, I'm not here to solicit.
And why are you here?
I'm here for your hospice visit. We spoke on the phone yesterday.
How do I know you're the same person?
Fair point.
It's the only point, young lady. So please, enlighten me.
Well, we talked about Nurse Boyle visiting with you last week and her enrolling you in our program. Then we scheduled this follow-up for today at 9 o'clock. We can call to verify who I am if that would make you feel more comfortable.
And leave you standing here looking like that.
I can wait in my car.
Whatever. Just come in.
The United States' involvement in the Vietnam War began in February 1961 and lasted until May 1975. Approximately 2.7 million American men and women served, and more than 58,000 service members lost their lives, and more than 2 million Vietnamese civilians and soldiers. Both men and women served in a variety of roles, women serving most often as nurses. In addition to the stresses of war, service members faced other challenges like lack of unit cohesiveness, environmental hazards, and America's failure to welcome them back home. Today in the U.S., nearly 50% of older men served in the military, an experience that shaped their lives in complex ways. Memories of this service can re-emerge later in life or appear for the first time at the end of life. While some memories contain positive experiences, others might include potentially traumatic events. A traumatic event involves exposure to actual or threatened death, serious injury, or sexual violence. However, people can have different perceptions of whether similar events were traumatic. It's important to consider that some reactions and interactions you experience might be shaped in part by the patient's military experience.
You're right, Mr. Bloom. We usually don't keep track of the hours we sleep. But if you had to guess, would you say you sleep less than 4 hours a night or more than 4 hours a night?
Would you like something to drink?
No, thank you. I brought my own. I also want to see first something. I appreciate that, but I'm fine.
Get back.
Get back!
You're okay, Mr. Bloom. Just breathe through your nose. Mr. Bloom? Mr. Bloom, breathe through your nose like you're smelling a rose.
I appreciate you inviting me in.
Yeah, well, you caught me off guard.
A lot of people feel that way when a nurse comes to visit.
Has nothing to do with being a nurse.
May I put my things in here, or would you prefer I put them in the kitchen?
Here is fine.
Mrs. Heltzel, I noticed your newsletter. Are you a veteran?
I was a nurse at the 91st evac in Vietnam.
That must have been quite an experience.
That's one way to put it.
Post-traumatic stress disorder, also known as PTSD, includes re-experiencing traumatic events through unwanted memories, nightmares, or flashbacks. Sometimes people struggle to remember key aspects of their experience, even when they want to. A person may even avoid thoughts, feelings, or reminders of their experience altogether. Other symptoms of PTSD can manifest as depression, self-blame, negative thoughts about oneself and others, or withdrawal from others and one's interests. Some people feel emotional numbness or have difficulty experiencing positive emotions. The stress of being on guard can be lifelong or can resurface later in life as trouble concentrating, problems sleeping, feeling startled, irritable, agitated, or aggressive.
I care for a lot of veterans, and we find sometimes later in life that they start thinking about their military service more, which can seem odd because it was so many years ago. Is that something you've noticed?
You don't want to know what I'm thinking.
If you feel like it's important and you're willing to share with me, I'd like to hear your thoughts.
It doesn't matter. Aren't you supposed to be taking my blood pressure or something?
Along with a few other things. But I want you to know, I'm here to support you any way I can. Is that a bonsai?
It was my husband's.
I was sorry to learn of his passing.
You want to just do this at the table?
Yeah, I'm okay with that.
Yeah, I guess if I had to describe it, I'd say I feel helpless.
Are you feeling that way more now? Other than these breathless episodes, has this feeling affected you in any other way?
He's been sleeping in the guest bedroom since we returned home from the hospital. I won't say why, he just says it's for the best.
Traumatic memories arising later in life may catch a patient off guard, especially when trauma occurred years ago. Some patients may disengage, hesitate to talk, but underneath want to be heard by an accepting person. Others prefer not to talk, but welcome help to feel more safe, at ease, or in better spirits. PTSD may further complicate the dying process, making recognition of symptoms essential. Awareness can lead to a better understanding, as well as a deeper appreciation of the patient's experience. Through this, individuals and families can navigate the end of life feeling less alone and more understood.
Wonderful. You know, in creating these videos, I think one of the things that we were thinking about is all the experiences that we were describing here, I think, I hope will resonate with a lot of you, and things that maybe you've seen on your own. And so I'd love to see in the chat, kind of how have you seen your experience? How have veterans with PTSD presented to you? We're seeing in the chat people chiming in with seeing nightmares and hyperactive delirium. And this video also highlighted a lot of the symptoms that we were seeing, some paranoia, or maybe some being a bit standoffish towards a new person who's visiting. Certainly the element of, is there some anti-Asian sentiment there, given that the person had served in Vietnam? And I think one of our key takeaways and the things we hope to stress here is that it can look variable from person to person. And so with the example of Mr. Bloom, we see that his presentation looks very different from Helen's. And some other people are chiming in and describing, covering up questions, avoiding answering, a kind of a defensive stance, sitting facing the door. So all these things are really highlighting just how variable it can look and how it might look like something different. So I think usually the first thought is in these experiences to think like, oh, well, it's not PTSD, it's something else. Like maybe this person is just, maybe this person is depressed, maybe this person is irritable. But often the first thought is not to jump to think like, has this person experienced trauma? And so we hope that in this video and other videos, you'll kind of see how both Chad and Tiffany are modeling examples of trauma-informed care, and not immediately being defensive or making assumptions about what the person has experienced.
I'm realizing it might help, Zach, just to say a little bit about what we envisioned, the conditions of each of these veterans that we're looking at. So Helen is someone who has advanced cancer and a lot of pain, and Les, the man, is someone who has advanced COPD and some mild cognitive impairment. So that may also, we tried to sort of think about how those underlying conditions might also feed into the symptom presentation of PTSD.
Thank you. Yeah, and a person's disease and a person's illness can certainly impact how their trauma might come back. And so, we see in Les an example of, first of all, what he's experiencing is something seems to be triggered related to his episodes of breathlessness. Yeah, and Nathan in the chat brings up a good point about asking a question of illnesses related to their service. And certainly, if you have been exposed to Agent Orange and have developed a cancer or an illness related to Agent Orange, and now you're going through that, that's certainly going to bring up memories or feelings about the government, about your experience in service. And all those things can be coming back, even if they haven't been present or maybe been buried for years. Yeah, Tyson does a great job of talking about the isolated lifestyle that we might see in some folks, and how, because of PTSD and because of trauma, maybe they've pushed a lot of people away. And so, when people become sick and they're in a position where now they are almost having to let more people into their lives, how that can be a really intense and challenging experience to go through.
Any other comments from Zach or the team, or should I move along?
We have a question about if it's okay for someone to ask audio question. Should we have them put it in the chat?
Sure. Just a technical question, I'm assuming, but we'll see.
Yeah, and I think if you have a question, if you want to put it into the Q&A, we can make sure that we address that. I see Ryan, there's a question coming in from Ryan, and we'll make sure to answer that, especially in some of the later videos that we'll show over this hour.
Okay, well, let's move to the second video. So the title of the second video is Responding to Trauma Disclosures. So that is what you're going to see here is you're going to see now it's now a few sessions later in the hospice and palliative care visits. You'll see a change perhaps in the level of trust, and you'll see a trauma disclosure. And we want you to look at the nurse and look at what she is doing in her response. And you might also perhaps think about things she is not doing. Again, a moment before the sound comes on.
Good morning, Mrs. Heltzel.
Morning. You can put your things in the kitchen.
Caring for individuals at end of life, especially in home, allows healthcare providers to become close with patients. Over the course of time, patients might see you as a supportive person to talk to. This connection may prompt patients to describe or acknowledge their past traumatic events. For some, this might be the first time they ever shared their story with another person.
Well, if you have medication you no longer use or are expired, I can help you dispose of those through a drug take-back program. Or I can help you do that here at home.
At home?
Great. Let me clean up and we'll walk through those steps.
I had no idea I could throw away medications at home.
Yeah, almost all medicines can be thrown into your household trash. You just have to mix it with something undesirable, like coffee grounds, cat litter.
How far along are you?
20 weeks.
Boy or girl?
We want it to be a surprise. Do you have any kids?
No. My first husband wanted to, but I was always nervous about it. He had 6 with his second wife.
6? I think I'll stop at 2.
Can't blame you. I may have been exposed to Agent Orange. That's why I was nervous. Soldiers would come in with their fatigues coated in it. I can't tell you how many of those uniforms we cut away. I had a friend, a nurse I'd worked with. She had a baby with a birth defect. Now, I don't know if that had anything to do with it or not, but I wasn't going to take that chance. There's so much I wish I could have left there, but you can't.
People often think of combat veterans as the only ones having traumatic experiences, but it can happen to nurses too. Is there anything about your military experience you'd like to tell me about?
You couldn't wear makeup because it was so hot. A little bit of lipstick, maybe, that was it. The soldiers, all they wanted was comfort, someone to remind them of their mother or a sister, girlfriend. One morning, before my shift, I couldn't get rid of the stench of death from the night before. I didn't know if it was in my head or if it was really there, but I couldn't go in like that. I had a bottle of perfume from R&R. I put some on and went to work. That night was a revolving door. It just kept coming in. We had to triage, decide first priority. We wrote vital signs on their chest with a magic marker. And all the time, they would just lay there watching you, watching your face, just watching to see what your reaction to their wound would be. There's one soldier, been out on patrol, stepped on a mine. He knew he stepped on it, so he warned everyone around him. They all scattered, found cover. As soon as he saw they were safe, he jumped. Somehow, he was still alive and conscious when we got him. But the back of his legs, all the way to his waist, were really bad. The chopper medic kept pouring fluids into him. We did the same. But just as fast as we put it in, it came pouring out. The thing that haunts me, though, is in the midst of all this chaos and blood and yelling, that young man looked me right in the eyes and said, "Ma'am, you sure smell nice." Those were his last words. He died soon after. I always carried a bottle with me after that. I'd put some on as soon as I heard a chopper coming in.
What a beautiful way to remember him.
Healthcare providers can support patients by actively listening without judgments, expectations, or distractions. Respond genuinely and refrain from offering platitudes, advice, or statements that may inadvertently invalidate or minimize a patient's experience. Providers may acknowledge or thank the individual by saying, "Thank you for trusting me with this memory," or "Thank you for sharing your experience with me." Follow up by asking, "In what ways can I continue to help you?" Or "I want to make sure you experience the healing that you need." In addition to the care you're receiving now, you can also speak with a mental health professional if you'd like. It's important to recognize one's own limits, especially for providers without advanced mental health training. Depending on your role, it is not the responsibility of a provider to become a patient's therapist.
Talking about your experiences can be difficult and also meaningful. And sometimes these memories can resurface when we least expect it. Is that what it's been like for you?
It's like a little black box where it's all been stuffed deep inside. It's always there. And I think if I were to open that box, I wouldn't last 2 minutes. So I keep it shut, lid closed. But every now and then, bits and pieces come out. It's difficult, but I think I'm okay with it.
That's an important step, Mrs. Hetzel, and I'm happy to talk with you about it again. But if you'd like to speak with a mental health provider in addition, or instead of me, I can help you with that too.
I'd rather talk to you.
Okay. And along with talking about your experiences, I'd also like to hear about your current coping strategies for dealing with these stressful memories when they come up.
You want to do that now?
We can start that, yes. Or we can continue our discussion about disposing of medicine. It's your choice.
The medicine.
Perfect. I think we left off at cat litter.
I think so.
Well, you can mix medicine with something undesirable like cat litter.
Providing psychotherapy for persons with PTSD takes time and special training. For this reason, creating a list of trained therapists for patient referral will be helpful. The deep, personal nature of end-of-life care can foster trusting relationships between patients, families, and providers. If a patient discloses details of a traumatic event, remember, listening with empathy is a powerful gift any person can offer.
Great. And so during the video, we've had some great examples kind of filtering into the chat about what do you see Helen doing? What do you think she's doing well? You know, I first want to kind of pause and point out just how different the relationship seems between Helen and Tiffany at this visit 5 versus visit 2. And so we can see that Tiffany has worked to build trust. And I think it's also an important reminder that, you know, sometimes our first visit, you know, we always put a lot of pressure on the first visit, and that the first visit or second visit have to go really well. And I know sometimes I worry about, like, well, you know, if I mess up that visit, or have, commit a faux pas or something, will I be able to recover? So I think this is a really great example of how, you know, what we see here is that they're building a relationship, and relationships build over time, and relationships also allow for the space to make mistakes. And we see how the relationship is different and more cohesive at this visit versus earlier visits.
And I think some of the nice comments that we see in the chat that give specific examples of what Tiffany was doing well is it being okay not to fill silence in some situations, and validating Helen's experiences and her military service, as well as asking open-ended questions and giving choices. And a few people commented on the parallel process between Tiffany and Helen, it being similar to Helen's experiences in Vietnam.
Yeah, and Valerie in the chat mentioned it could be a challenge to slow down and not try to comfort people too quickly, or to make reflections too quickly. And I think something that I practice and have to often remind myself to do is, like, after someone is telling me something, or during the time that someone's telling me something that I know is important, that afterwards, just to be able to take a breath and to just, kind of, I think about myself and slowing myself down, and also how that, how the patient's also picking up on the fact that, I'm taking my time to respond. I think patients really appreciate when we are selective with our words, and the patients are selective about what they tell us. And so I think it's a nice opportunity to kind of model that, what I'm going to say might be really important to you, and I want to take the time to come up with the right way to say it. And so Tiffany does a great example in this video. But it can be really hard not to immediately jump in and say something. And I think that's a skill that comes with time and practice, and also recognizing that there's not, like, one perfect thing that you're going to say, but that sometimes just giving space is one of the best options.
Zach, I loved how you used the phrase, take a breath. I'm a psychologist by training, so I have done psychotherapy with older veterans with PTSD. And I have found that focus, when you're listening to things, and if you're being empathic, you're aware of your own distress. And I find just focusing on my own breathing, focusing on, and it's going to be different for everyone, but some of my own tricks, I really try to sort of locate myself in my body and, you know, my body on the chair. I, I think that simply being a witness without judgment is such a gift. So I, you know, try to think, you know, I need to convey that I have a backbone and I can hear this. So I will sometimes sort of think about my backbone as I'm listening. And I don't know if other people have little tricks like that that they use. Another thing I try to think about and is that we're connected through our common humanity. So I just sort of try to feel and visualize that connectedness. All of these are things that I think sort of calm me down and help me be present and to help me refrain from jumping in too quickly.
Yeah. Yeah. I will sometimes think about like, I'll have a moment where I just have a recognition of just how sacred this feels. And, you know, that doesn't come from, you know, that comes from like providing end of life care and not necessarily from a background in psychiatry. And I think, you know, one of the things that we hope we can model is that so many of the skills that you all have taking care of folks at end of life are really applicable to people who have also experienced traumatic things. And so, you know, we're really wanting to be explicit about that your role is not to become a person's therapist, but that really empowering you to feel like that so many of the things that you do on a regular basis can be really deeply meaningful to people as they're kind of maybe telling someone for the first time what they've been through.
It is astounding how commonly you hear that. I've never told anyone this. And I'm always thinking, oh my gosh, this person's 80 and they've carried this around for 50 years. So what a tremendous honor that they are trusting you with that story.
Yeah, I couldn't agree more. We also see, like in the video, one of the Zaza talks about Tiffany's eye contact and her presence, and just, you know, her body language. Like so much of communication is body language. And there's a moment in the film where Tiffany kind of reaches out for Helen's hand, and Helen has her hand there for a second and then pulls her hand away. And so I think that's great because, you know, we see Tiffany wanting to make a connection, but, you know, the part I'm left with was like, was it a connection that Helen felt was helpful or not? And so I think, you know, to some degree, like that can be an opportunity, you know, maybe afterwards or asking your veterans of like, you know, when you're experiencing frightening things, like what would be the best way for me to comfort you? Would, you know, would a therapeutic touch on your hand or your shoulder be helpful? And I think also asking folks what is the best way to take care of them is also really empowering them. You know, everyone kind of has this, you know, innate ability to some degree to heal themselves, I think. And, you know, I think what we see in the video here is that a lot of what Tiffany and Chad are doing isn't particularly active, but is really giving space for the person to kind of have their own process. Yeah, Vanessa brings up this issue, and she typed into the channel. So I think pulling her hand back was how she closed the box, and I think allowing people to have that ability to decide when and how they open and close that box is really important. So when that box is closed, you know, it's really, you know, is it really our role to be pushing to reopen it? And you know, I would say at this phase of life, like that might not be the most important thing. Depending on someone's prognosis, certainly you want to make adjustments on kind of how much pushing and pulling, but being able to really, you know, that's a part of respecting patients' autonomy, is when they're not wanting something, being able to back off. And Valerie again chimed in just how important the nonverbals, body posture are, and just like with right now with masks being on, how much we have to convey emotions from the top half of our face. And sometimes like really kind of having to over exaggerate or, you know, really thinking about how my body language and not necessarily my facial expressions are conveying compassion and warmth to folks.
These are such wonderful points. So I'm going to transition to the third video. Thank you all for continuing to chat and share your ideas with one another. So the title of this third video is Cognitive Impairment and PTSD. So as we mentioned, Les, the veteran, we're going to return now to the male veteran. He has mild cognitive impairment. So he's pretty articulate here, but the idea is that he's going to be a bit more easily confused and have a little bit more difficulty orienting himself. So again, we want you to look at what you think this nurse is doing so well and share those ideas in the chat.
Les, you're here in your home. I'm your nurse, Chad, and I'm here with you. Your wife is here too. I want you to look around. Can you see the room? Your wife? We're at your home, Les. The walls are white, your chair is brown, and I'm checking your blood pressure. You're safe. Les, my blood pressure monitor is still around your arm. May I remove it?
He's been doing that a lot since your last visit.
Does it seem to happen most when looking at the ceiling?
It's like he's afraid something's gonna fall on him. But then, sometimes he just stares into the distant, like something's out there.
And the reaction, is it more like what happened 2 weeks ago or today?
It varies, but they're definitely more aggressive at night. I think that's why he wants to sleep separately.
Les, we noticed you seem uncomfortable when looking up at the ceiling or looking off into the distance. Can you tell us what's happening in that moment?
The air. It touches me. I can smell him.
Would it help if we closed the window? Les, we closed the window. Can you still smell it?
He's still there. I can't see it. He's still there.
Are you remembering something?
I can't get away.
during a time you were in danger? Are you remembering Vietnam? You survived, Les. You're safe at home with your wife. We'll do everything we can to make sure you feel safe.
Symptoms of post-traumatic stress disorder, or PTSD, may present differently in those with cognitive impairment. Such individuals are more at risk to become disoriented by sounds, smells, memories, and flashbacks. Some patients may be able to verbally communicate their experiences or fears, while others may rely on nonverbal communication, such as looking afraid, striking out, or trying to move away. Using techniques called grounding may aid in bringing the person back to the present. Change the environment, keep a nightlight on, play music, or draw attention to the here and now. For example, describing the room and how the person is physically connected, such as saying, "You were sitting in a soft chair." A person experiencing a flashback may have difficulty orienting themselves to present-day reality. Because of this, they may believe a person wants to harm them when in truth, that person wishes to help them. It is sometimes hard to know what is causing behaviors. Knowing someone's trauma history can provide clues.
Can you tell me what job you had in Vietnam? Or Mrs. Bloom, can you?
He always said he was an engineer.
Les, were you an engineer in Vietnam? Would you like to share your job with us, Les?
Tunnel rat.
Tunnel rat?
Did you have experiences as a tunnel rat that bother you now? Would you feel safe talking about how those experiences impacted you? Understand. Would it be okay if I check in with you at another visit? We can take it slow and figure out together how you can share so you feel in control and it's less upsetting. Les, I wasn't able to get a good reading on your blood pressure. Would you like me to recheck that now or after I listen to your chest and breathing?
After.
Great. Can you sit up for me, please? Perfect. If you start to feel uncomfortable, dizzy, or anything else, let me know. We can slow down, okay?
Explaining what you plan to do and offering simple choices remains central to providing trauma-informed person-centered care, especially for individuals with dementia. This can help a person gain a sense of control when confused or agitated, or when memories become overwhelming. Aggression, physical tension, and pain may also be present, but relating it to PTSD, medical illness, or a combination can be hard to determine. For example, difficulty sleeping can be a symptom of PTSD and can be worsened by nightmares, but is also common in other medical conditions. If you know the person's story involves military experience, then it may be helpful to consider its role in contributing to or worsening these symptoms.
As veterans age, many carry lasting effects of trauma, which can manifest in unique ways late in life. But if a person is unable to share information because they are feeling confused or they find it too difficult, we may need to find alternate methods of understanding them.
You think he has PTSD?
He seems to show those symptoms.
I knew there was more to it.
I've been having the same thoughts over the past couple visits. I started to notice he's been more impulsive, and his aggressive behaviors and withdrawal were worsening. Couple that with what seems to be flashbacks. Mrs. Bloom, I think it's time we discuss if there are other things we need to do to best care for your husband.
Alone in the dark, knowing someone is waiting for you, and you still go in?
Your husband's a brave man, Mrs. Bloom.
Yes.
Family members may not be aware or are vaguely aware of traumatic events experienced by their loved ones. However, they may be conscious of potential triggers. For example, a loved one with cognitive impairment may get more agitated in a shower if it reminds them of a foxhole collapsing during a rainstorm. It can be helpful to ask family members when they notice heightened agitation or anxiety. Keep in mind, family members may feel more distress seeing their loved one in distress, but not knowing the underlying reason. Both patients and caregivers benefit from the support, reassurance, and education about how early traumatic experiences may re-emerge at the end of life. For a healthcare provider, understanding PTSD, how it may affect the dying process, and how it may present differently in patients with dementia will help you care for patients and their families at the end of life.
So our discussion questions for this one is, and we'd love to see this in the chat. And when you respond, make sure you type attendance and panelists. But what skills do you see that Chad is applying? Or maybe in this instance, what else do you try in these situations? And while folks are typing things in, one of the questions that came in from Ryan said, some of the symptoms of PTSD overlap with signs of dementia, like anger, isolation, and disorientation. So what are some special considerations for care if they have a verified history of both PTSD and dementia? I think one of the important things that, one of the things that we know about, particularly older adults, is that between 70 and 90% of older adults have experienced at least one traumatic event in their lifetime. So I think a great way is to kind of enter with the assumption that people have experienced traumatic things, and that the way that we might provide care for someone with PTSD and dementia doesn't have to look too different from how we would provide care to all of the people that we take care of. And so I think assuming a trauma history is a great first step. If you do know that someone has PTSD and dementia, I think one important thing is to think about the environment and think about how the environment might be perceived as dangerous or unsafe. Things like if someone's on a locked dementia unit and how that might be really frightening to someone with PTSD and dementia. Or if someone's coming, if an unknown person is coming into their room, or an aide, and so can you set up care in such a way that you have consistency between staff members? And so maybe there could be some memory of that. I think also one important thing is being able to use healing or soothing music. Sometimes we think that memories of music are held differently. And so sometimes that's a way that I will modify the environment to try to make it a more calming place. Being mindful of kind of what type of touch you're using, and trying to observe the patient if there are particular times of the day that seem better or worse. And so I think one important part is just kind of thinking about consistency and thinking about what modifications to the environment can be made. One of the, and I'm just looking through the chat, seeing what other things have come through. I want to highlight, one of the examples, that Mr. Bloom shared with his wife, that he was a combat engineer, and then later says in this context, a tunnel rat. And that was tunnel rat is a euphemism or a name given to individuals who were climbing through tunnels to look for enemy forces in Vietnam. It was used by American forces and Australian forces. And it was staffed by often combat engineers. And so people might minimize certain parts of their military experience so as not to have to explain what it is or to talk more about maybe particular traumatic memories. And so, we see pretty regularly that someone maybe, says, well, oh, what was your role in the military? Oh, I was just a cook. Or, I did something else. But just because someone has a role that isn't traditionally thought of as a forward-facing role, they might also still have traumatic experiences or experiences of in combat. So it's important to be aware of that as well. And also just thinking about how, especially Vietnam, individuals' homecoming impacted maybe how they told their military story. So if when you arrived home, you were back from Vietnam, you arrived alone. And so you weren't necessarily traveling with a battalion after you've been in for a year, you come out. And so you're just kind of arrive in the US, you're on the base, and then you're kind of you sent off the base, sometimes with a bus ticket and some cash. And you're arriving back in a pretty hostile environment after been in a really hostile, frightening environment. So I think that we also see all the time how that impacts how people describe their military service. But older adults might be starting to re-engage and think more about what they did and wanting to talk about it in a different way that might be new for family or people around them.
People are also sharing in the chat about the caregiver piece and making sure to loop the caregiver in. And I think that's a really great point. Oftentimes caregivers are also unaware of how to respond, what to do. It's new for them as well, and really providing that psychoeducation and education about PTSD can just be really normalizing. So I think we saw a really nice example of that at the end of the video. So it's a really good point, caring for the caregiver.
Yeah, and there's a great point by Kristen O'Grady as a music therapist. And, I think this is like one of the music therapist is like such I feel like an underutilized role in hospice, but one of the most important people that if I have a challenging case, one of the people that I really want to reach out to and try to collaborate with and see if they have great ideas about how, how we might be able to best use music to be able to help someone or to calm someone. And so, yeah, definitely before you're going to utilize music, if you have a music therapist on your staff, it's a great idea to check in with the professionals first. I think one of the final points is Abby earlier brought up, what do you do when patients want to talk about trauma? And I think that's depending on the prognosis, if they have they might have months prognosis, then it's a great time to talk to them about engaging with a therapist and being able to talk about some traumatic experiences. So just because someone is at the end of life doesn't mean that you wouldn't use that opportunity to maybe be able to do some more processing work. So I think at that point, you really want to have speak with either a mental health professional or the PTSD consult line through the VA or whatever resources that you have to kind of figure out, is this person at the right time to be able to talk about it, and how are we going to plan psychotherapy in the context of their illness?
Well, you'll see up on the slide here, we'd really like your feedback on these videos. And I know the Office of Rural Health really wants your feedback as well. So there's two ways to do that. I'm sure you're able to read, but I'll just go through them. Most smartphones, if you open up your camera and you put it in front of this slide, it will capture this QR code. It may not work for you if you need a special app, or maybe you don't have a smartphone. In which case you can also, someone from our team should be entering a link into the chat as well, and that should open a second window for this survey. If you're not seeing that second window, you just may need to exit your full screen mode. So it's really just about 6 questions. And if neither of those things work for you, I think Rachel on our team is actually going to type the questions in there. We just want to ask, what'd you like? What didn't you like? Would you imagine using these? And some other questions you'll see there. I want to again thank everyone who participated in the focus groups and the surveys that launched this project. It was really your perspective, which we saw in the chat today, that helped to shape the content of these videos. And we really were hoping they would be realistic and helpful. So thank you so much. We were just blown away by the generosity of really busy clinicians to make time to talk to us about what you're doing. I'm just going to leave that up on the screen so people can keep responding. And I invite anyone else from our team if you have any closing comments or thoughts.
Yeah, I thank everyone for joining, and it's really been an honor to use everyone's input to be able to craft these videos. And so thank you, and thank you for NHPCO for hosting us today.
Yeah, thank you, Catherine. All right, everyone, have a good rest of the day. Take care. Thank you for your time.
Thanks, everyone.
Catherine or Emily, just a reminder that we'd love to have the chat saved if you